Good morning, everyone. UNMICRC Institute of Cardiology and Research Center is organizing weekly academic session for continuous cardiac education. We have successfully completed previous academic sessions, and I thank you for being part of it. Our this week's academic session would be on single ventricle physiology, which will be taken up by Dr. Jigar Patel, sir, who is Associate Professor in Department of Cardiac Anesthesia at UNMICRC. He has 13 years of teaching experience.
Good afternoon to everyone and thanks for joining for this lecture. Today topic of my presentation is single ventricle, anatomy, physiology and management strategy. We will see this lecture through definition, history, pathological anatomy, then embryology and the variables of physiological derangement. Then we will see common type of single ventricle followed by clinical feature and then management strategy as a Fontan pathway. Now by definition, single ventricle is a congenital cardiac malformation that led to completely well developed ventricle, and functionally there is only a single ventricular chamber that supports both pulmonary and systemic circulation. Now in history part, in 1858 Thomas Peacock first time described the heart with two atria and one ventricle. Later on, Dr. Taussig in 1939 observed single ventricle with a diminutive outlet chamber. After that, cardiologist from Mayo Clinic, Dr. Van Prague, in 1964 with his colleague defined single ventricle as an entity in which both an AV valve is emptied. But later on, Dr. Anderson have made certain observation and he divided part of ventricle as a ventricle. Must have a three chamber like inlet portion, which is a part from AV annulus to the insertion of papillary muscle. Trabecular portion, this is a portion between inlet and outlet and it consists cavity of the or apex portion of the ventricle, and the third is the outlet portion. This is a non-trabeculated region below the outlet valve. So based on this observation, he defined ventricle must have a chamber with greater than 50% of inlet portion with or without outlet, and rudimentary ventricle is the chamber with less than 50% of inlet portion. But this definition is very confusing. So later on in 1984, in response to the argument against definition of his ventricle, Anderson introduced a new term, that univentricular AV connection. In this, he divided ventricle based on atrioventricular connection. Now we will see pathological anatomy of single ventricular heart. So it depends on three things. First is the ventricular morphology, then atrioventricular connection, and the third is a ventriculo-arterial connection. So based on ventricular morphology, 80 to 90% cases of univentricular heart have a LV morphology with RV as an outlet chamber, as you see in this image. So remaining 10 to 25% of cases of univentricular physiology has a RV morphology with LV as a trabecular pouch, as you see in this image. The LV is a trabecular pouch and minute cavity. And in 5 to 10% of cases of univentricular heart, there is an indeterminate morphology. So there is neither an outlet pouch or nor a trabecular chamber. Now, second point of classification based on anatomy is depend on atrioventricular connection. So in atrioventricular connection, there are three types possible. First is a double inlet. So here both AV valve is emptied in a single chamber. So most of the time there is a double inlet left ventricle and rarely there is a double inlet right ventricle. Here both valve is the mirror image of each other. So if it is double inlet LV, then both are mirror image mitral valve. Second type based on atrioventricular connection is a single inlet. Here one is the patent valve and there is associated atresia of the other valve. So if there is atresia of right AV valve, then it is tricuspid atresia, and if left AV valve, then it is mitral atresia. And third type is a common inlet. Here both AV valve, so there is no to separate AV valve, but there is a common AV valve which emptied on a single chamber. It may be LV type, RV type or indeterminate. Now we have to understand two terms. The first is overriding. So overriding is a partial commitment of a AV valve to the contralateral chamber. It is due to malalignment of atria and ventricular septum, and overriding determines the AV connection to the particular chamber. So If annular commitment of more than 50%, then ventricular chamber establish connection with valve. As you see in the image, the first heart is with concordance without any overriding, and the second image there is a slight overriding of a tricuspid valve. So, but it is a less than 50%. So, it is a concordance with overriding. In the third image, you can see the overriding is the more than 50%. So, it became double inlet left ventricle. So, tricuspid valve is committed to the LV, and it called double inlet LV with overriding. And in the last image, there is a double inlet and the both valve committed to the LV. So, it is without overriding. So, it is rule of 50 that overriding must be more than 50 for the commitment of valve to the particular chamber. Next important thing is the straddling. While overriding is the feature of valve, while the straddling is the feature of tendinous chordae and papillary muscles. Here, insertion of chordae to the contralateral ventricle through VSD occur. So, as you see in the image, the tricuspid valve chordae is attached to the LV through VSD. So, whichever valve is straddling to the opposite side, they became this chamber become hypoplastic. So here RV become hyperplastic. In first image RV is slightly hypoplastic, but in the second image it is totally hypoplastic or rudimentary. So this straddling of heavy valve leads to regurgitation, and it often large. Now third important types based on anatomy is ventriculo-arterial connection. So, ventricle with LV morphology, there are two type of VA connection possible, but the most common type is the discordant VA. So, here aorta will arise from the rudimentary RV, as you see in the image. It is a rudimentary RV. It is located anterior superiorly, either on the right side or the left side. If it is located on the left side, it is called inverted chamber, and if it located right side, it will called non-inverted chamber. This outlet chamber is often smooth wall, and it is often restricted due to hypertrophy of muscle. Secondly, here pulmonary artery arises directly from the LV. So, many times there is a pulmonary outflow tract obstruction also present, and the reason is the posterior deviation of the infundibular septum, or sometimes there is a herniation of valvular tissue inside pulmonary tract. Now, second type possible with LV morphology is a concordant ventricular arterial connection. So, here what happens, aorta will arise from the dominant LV and PA will arise from rudimentary RV, and there is a simultaneously also pulmonary stenosis is present. This type of anomaly is called Holmes heart. So, in 1824, Dr. Andrew Fernando Holmes published autopsy observation of 21-year-old man who died with chronic cyanosis and congestive failure. So, this patient has a double inlet LV with VA concordance and pulmonary stenosis. Now, another type of ventricular arterial connection is present when there is a univentricular RV morphology, which is rare, but in that case, both great artery will arise from right ventricular, or it is called double outlet right ventricle. And the pulmonary, another possibility is single outlet with pulmonary atresia. And if there is a univentricular indeterminate morphology, then there is no outlet chamber or no trabecular pouch, and both great artery arise from the single indeterminate ventricle. Now we will see embryonic development. On embryonic development of the heart, the chamber division occur before 8th week of development. So here atria will connected to the ventricular component with endocardial cushion. So in ventricular component has a two portion. One is the inlet component and the outlet component. This inlet component will give rise to left ventricle, and the outlet component is give rise to RV. So whenever there is excessive growth of this inlet component, it will lead to double inlet left ventricle, and similarly when there is excessive growth of this outlet component, then it will be double inlet right ventricle. But if this both component grow as a single and without any separation, then it will become double inlet with indeterminate ventricle. Now we will see variable of physiological derangement. So it depends on 6 factors. First is the inherent mechanics of single ventricle. In biventricular heart, Both ventricle help each other in emptying during inspiration and expiration. It is called ventricular interdependence. But in single ventricle, that this ventricular interdependence will lost, and this will give rise to abnormal systolic and diastolic function. Second variable is the morphology of right ventricle versus morphology of left ventricle. So here single ventricle supply both systemic and pulmonary circulation. So to overcome this volume load, there should be adaptive increase in the ventricular mass. So LV will take care of this, but with RV morphology of single ventricle, there is an inadequate mass related to chamber size. So it will reflect as a poor adaptation. So third variable is the morphology of and function of single this AV valve. So if this AV valve is guard the atrioventricular junction, if it is incompetence, then it will cause volume overload on the single ventricle. If there is a stenosis or atresia of this valve, then it will cause obstruction of flow either at the level of valve or at the level of ASD. The location of outlet chamber will determine the degree of mixing within a single ventricle. If the outlet chamber located on the favorable side, then there is a proper mixing occur. If it is not located on favorable side, then mixing will not occur appropriately. Fourth factor, or I would say fifth factor, is a pulmonary vascular resistance. If pulmonary vascular resistance is high, then it will decrease pulmonary blood flow. But if naturally pulmonary vascular resistance is very low, and it will cause volume overload to the single ventricle. Last factor is presence of pulmonary stenosis or aortic stenosis. So if there is a aortic stenosis, then it will divert blood flow to the pulmonary artery, and it will increase pulmonary blood flow and ultimately volume overload. Similarly, if pulmonary stenosis present, then it will lead to decreased pulmonary blood flow and patient present with cyanosis in early life. Now we will see the common type of single ventricle. So there are 5 common types. The first one is the heart with common inlet AV connection. It is double inlet left ventricle or double inlet right ventricle. Second type is heart with common AV valve and only one well developed ventricle. So it is unbalanced common AV canal defect. Third type is a heart with absence of one AV connection. So if it is absence of right AV connection, then it is tricuspid atresia, and if absence of left AV connection, then it is mitral atresia. Other rare type are pulmonary atresia with intact IVS and DORV with remote VSD. Now we will see this common type one by one. The first one is the double inlet left ventricle. It is the most common form in Van Prague original series of the study of single ventricle. So double inlet left ventricle present in the 3 form. First is a double inlet left ventricle with LTGA type. Here RV is on the left side. And second is a double inlet left ventricle with DTGA type. Here RV on the right side. So in this double inlet left ventricle with TGA variety, there is a subaortic obstruction present. As you see in the image, it is at the VSD level, and it is due to ventricular hypertrophy, and sometimes it is also developed secondary to pulmonary artery bending. And the third type of the double inlet left ventricle is the double inlet left ventricle with normal ascending great artery. It is, as we discussed previously, it is Holmes heart. So here pulmonary outflow tract obstruction present, and the reason is the deviation of infundibulum septum or herniation of valve tissue. So in double inlet left ventricle, there is conduction abnormality present. This is due to non-branching bundle which course around the right rim of VSD. Second common type is the double inlet right ventricle. It is present in the 5% of cases in the series reviewed by Van Prague. Here, as you can see in the image, both atria connect to the morphological RV, and the LV is as a rudimentary chamber, and it is located posteriorly and inferiorly like a hip pocket. Here ventricular arterial connection possible is the double outlet or a single outlet with pulmonary atresia. And the AV valve abnormality are commonly present like straddling or common AV valve. Now third common type is a double inlet ventricle via common AV valve. So here both atria connected to the one ventricle by common AV valve. It is a form of AV septal defect, and 40% of these patients have a asplenia. Here dominant ventricular chamber, if it is LV, then it is type A Van Prague. If it is RV, then it is type B. And if there is an undifferentiated myocardium, then it is type D. Here ventricular arterial connection possible is a double inlet, double outlet, or single with pulmonary atresia. And the AV valve abnormality is commonly present like valvular stenosis, hypoplasia, or regurgitation. Now, one of the most common type of single ventricle is a left AV valve atresia. It is also known as mitral atresia. It occurs in 2 to 3% cases of CHD. Here, underdevelopment of the left side of heart and atresia of aorta and mitral orifice. So, it will lead to hyperplasia of left side of heart. It is also known as HLHS. Here, LV is small and non-functional and totally atretic. Here, pulmonary venous return come from LA through PFO or ASD and come to RA. Here in the RA, it mixes with the systemic return and goes to the RV. Then it will reach to MPA and goes to pulmonary circulation, and part of it goes to the systemic circulation through patent ductus arteriosus. Last common type of single ventricle is a right AV valve atresia. It is also known as tricuspid atresia. It is present in 1 to 3% of congenital heart disease. Here atresia is of two types. First is the muscular atresia, which is the most common, and the second is the membranous atresia. Here inlet portion of the right ventricle is absent, and RV is composed of infundibular portion and incompletely from trabecular portion. Here if there is a large VSD, then it leads to better development of trabecular portion of RV and larger RV cavity. And if VSD size is small, then RV become rudimentary or maybe absent. So tricuspid atresia again classified in a three variety based on normal residing great artery or arterial relation. So the first type is a tricuspid atresia with normal residing great artery. It is a more common type of tricuspid atresia as it is present in 69% of total tricuspid atresia case. So it is further divided in three parts, A, B and C according to pulmonary artery. So in type A there is a pulmonary atresia without VSD. So it is a duct dependent circulation. And the type B is the pulmonary stenosis with VSD. And it is a most common type of tricuspid atresia. It is 51% cases of total tricuspid atresia. It is a type 1B. And the third type is the large VSD without PS. So here pulmonary overcirculation is present. Similarly, type 2 is present with DTGA and tricuspid atresia. In DTGA, tricuspid atresia type A have a pulmonary atresia but with VSD. So type B has a pulmonary stenosis with VSD, and type C is a no PS, so it is a pulmonary overcirculation. In this type, there is commonly restricted VSD and coarctation of aorta is also present. So it is a total 28% of the total tricuspid atresia population is a type B. Now third type is a very rare. It is only 3% of total tricuspid atresia, and it have either PS or AS. Now single ventricle patient present with four type of clinical feature is divided on the basis of clinical feature on the four group. The first group is present with obstructed pulmonary blood flow. So here a duct dependent pulmonary blood flow, and it will present in neonatal life with progressive hypoxemia, cyanosis and respiratory distress. It is due to closure of the duct. Second group of patients have either obstructed systemic blood flow or duct dependent systemic blood flow. So naturally they will also present in neonatal period, and they will present with tachypnea and poor feeding or signs of systemic low output like acute tubular necrosis, necrotizing enterocolitis, congestive heart failure or multi-organ failure with either poor growth and development. Third group of patients have a unobstructed systemic and pulmonary blood flow. So they have pulmonary overcirculation, and they will present with mild congestive heart failure and hypoxemia with or without visible cyanosis and no end organ dysfunction. But this group of patients will present lately around the age of 1 month, while the previous two group present within a 15-day of life. Fourth group is the patients with unobstructed systemic blood flow and mild pulmonary stenosis. So they are asymptomatic and they have protective pulmonary vascular bed due to pulmonary stenosis, and it will present lately around 2 to 3 months of the age. So patient with single ventricular heart with univentricular LV morphology with their natural history, the 50% of patient will die within a 14 years without intervention. And with if there is a RV morphology, then 50% patient will die within a 4 years without any intervention. So we have to manage them surgically. So management of single ventricle is based on the Fontan pathway. It is developed by Dr. Francois Fontan and Dr. Turzer from Brazil. In 1960, they concurrently introduced the most disruptive and surgical innovation in congenital cardiac surgery. So through this operation, there is a simultaneous elimination of volume load and cyanosis, and the highest possible cardiac output is achieved at rest and with exertion with lowest possible central venous pressure. So initially they done this operation for tricuspid atresia, and it is also known as a right heart bypass. So over the time there is a multiple surgical modification occur and additional procedure like Norwood and hybrid procedure, then BDG, and along with the medical management between the interstage, it will known as Fontan pathway. And through this Fontan pathway, the circulation HI is called Fontan circulation, and it leads to survival in the 4th and 5th decade of life with successful pregnancy and acceptable quality of life. Now this is the Fontan pathway. It divided in the 3 stages. The first stage is the surgical management in the neonatal period. So neonate present with any obstruction to systemic or pulmonary blood flow, they will surgically manage in this stage. Then after this stage there is a brief interstage, and once child reach to infancy and develop cyanosis, then in stage 2 superior pulmonary anastomosis is done, and after that when child reach around 2 to 4 years of age, then a final Fontan operation done. So between this stage there is an interstage, so you have to monitor the patient and regular follow-up is done, and this whole pathway is known on the name of Dr. Fontan as a Fontan pathway. So before seeing each stage of surgical management, we will see univentricular heart physiology. So in the normal heart, it is a series circulation where blood from RA travel from the whole body and return to the RA. It is called series circulation. While in the transposition, there is a parallel circulation. So both circulation mixes at certain point. Previously, single ventricular circulation is known as a parallel circulation, but it is wrong. It is a multi-distribution circulation. Here, cardiac output will divided into part of it go into pulmonary circulation and part of it go into systemic circulation. And if there is a regurgitation, then part will go as a regurgitation. So it is a multi-distribution circulation, and here single ventricle function as a both ventricle, then that leads to volume overload condition. So if we suppose patient has a balanced pulmonary and systemic circulation in single ventricular patient, so it will not give optimal oxygenation. So if there is both a pulmonary blood flow and systemic blood flow equal, then you will get pulmonary venous oxygen of 95%, but systemic oxygenation will be 60%. So it will impair oxygen delivery. So there is always a pulmonary overcirculation in single ventricular patient. It is around ratio of 2:1. So if there is a 2:1 ratio, then you will get 85% of saturation, and it will maintain systemic oxygen delivery. But this overcirculation leads to pulmonary congestion, tachypnea, respiratory distress, and patient develop congestive heart failure. And it will develop over the weeks, so it will present clinically. Now we will see neonatal surgical reconstruction. The goal of neonatal surgical reconstruction are to achieve unobstructed systemic blood flow. So if there is a system obstruction in the systemic blood flow, that will leads to ventricular hypertrophy and ventricular function. So we have to correct it in this neonatal period. Second goal is approximately limited pulmonary blood flow. So we have to control pulmonary blood flow and provide adequate pulmonary blood flow to grow pulmonary artery, and with the simultaneously reduce the risk of elevated PVR. And we have to correct distorted pulmonary artery if present during this stage. Another goal is we have to achieve unobstructed pulmonary venous return. So because if there is obstruction in pulmonary venous return, like if patient have a TAPAC, so you have to correct it in this stage. Otherwise, it will cause pulmonary venous hypertension and elevate PVR. Last goal is to achieve unobstructed systemic venous return, because it will lower central venous pressure and improve cardiac output. Now, the first operation which is done in the neonatal period is the BT shunt. It is indicated in patient with restricted or duct dependent pulmonary blood flow. The goal of the operation is to provide stable and reliable source of pulmonary blood flow, and it is indicated in the patient with normal ascending great artery and with normal arch branching. So it is performed in first or second week of life, and in classic BTSN, the subclavian artery is divided and anastomosed directly to pulmonary artery. But you have to sacrifice subclavian artery in classic BTSN. So modification later on occur, and currently we are doing modified BTSN. It is we put PT epigraph between subclavian artery and pulmonary artery ipsilateral side. This operation is done by thoracotomy. And the disadvantage of BT shunt is that PDA cannot be controlled or ligated at the completion of this procedure. So, if both shunt and PDA are leads to hypotension and low velocity flow, and it will cause shunt thrombosis. Similarly, if larger size of shunt is used, then it will lead to diastolic hypotension and reduce coronary blood flow and systemic blood flow. Similarly, if small size of shunt is used, then it will cause hypoxemia and it will not solve the problem, and there is a reduction in saturation when patient is awake. So post-operatively, saturation of 85 or 75 to 85% indicate adequate shunt flow. Another neonatal surgical is the surgery of choice is central shunt. If patient is not suitable for modified BT shunt, then indicated is a central shunt. Here, if patient has a small branch pulmonary artery or abnormal arch branching, then central shunt is preferable. So here it is done through the midline and end to side anastomosis of MPA with ascending aorta. The advantage of central shunt is PDA can be ligated after construction of the shunt, and innominate artery and proximal branch pulmonary artery are more easily accessed. And if required, CPB support can be used for construction of the shunt. Third procedure to increase pulmonary blood flow is PDA stenting. Through PDA stenting, we can achieve stable source of pulmonary blood flow, and it was first reported in 1992. It provides equivalent result to a surgical shunt in patient with suitable anatomy. Newer coronary stent have a better flexibility and trackability and making this duct stenting safer. So these three procedures are for increased pulmonary blood flow, and this procedure require optimum perioperative care. So in the perioperative care, we have to ensure continued patency of the PDA through prostaglandin infusion. These are the neonates, so there is a high chances of coagulopathy and bleeding. So we have to take care of this. There is a minimum fasting period, and good pre-medication is required, because crying will lead to further reduction in the pulmonary blood flow. These patients have an immature myocardium, so anesthesia induction and maintenance with high dose narcotic with inotropic support is required. Artery line should be put on the femoral artery to measure central venous pressure, central arterial pressure, and a central line is put on the IJV. We have to avoid the IJV or subclavian, as it will lead to venous thrombosis and it will complicate further stage of management. Initial day, this patient require mechanical ventilation and inotropic support, and there is no need to reverse heparin with protamine, as we also start heparin post-operatively in the infusion dose range from 5 to 10 units per kg, and aspirin also given from the same day. In the first operative day, post-operatively, these patients have some degree of hemodynamic instability and metabolic acidosis, so you have to be vigilant for that. And the result of this surgery is early mortality is very low, as similar to TOP, and 5-year survival without definitive surgery is 90%, and 10-year survival is 85%. Deterioration is due to relative narrowing of the shunt, and it will lead to cyanosis and LV cardiomyopathy. Now, in patient with unobstructed systemic and pulmonary blood flow, we have to control and regulate pulmonary artery flow. So it is done by pulmonary artery bending. So by doing pulmonary artery bending, we relieve the volume load to the ventricle and reduce the pulmonary artery pressure. Pulmonary artery bending allow remodeling of the pulmonary vascular bed for subsequent palliation. So in neonate, the PVR fall around 2 to 3 weeks of the life, and it is the best time to operate for the pulmonary artery bending. This surgery is done through the midline sternotomy, and here length of the band is decided according to Trussler formula. According to the formula, length of the band should be 20 mm plus thighs weight in kg. So if there is a 3 kg, then you have to use 23 mm size of band. So in patient with TGA and neonate, there is a unfavorable streaming of blood in the ventricle. So they are more prone to hypoxemia. So we have to keep band loose, and the length should be 24 mm plus child's weight. Now perioperative management in PA band, we have to look for this point, like we have to adjust the band to achieve distal pulmonary artery pressure around 15 to 20 mm of Hg, or it is 1/4 of the systemic blood pressure, and the saturation should be 80 to 85% at 50% FiO2. So this PA band have a high early mortality as 25 to 35%, but in current era it goes below 5%. So we have to measure pulmonary artery pressure and femoral artery pressure intraoperatively, and CVB may be required if there is simultaneous atrial septicectomy should be done. So we have to maintain mean blood pressure with inotropic support in intraoperatively as well as postoperatively. And in case of cardiac arrest, these are difficult to resuscitate, and we have to divide the PA band so that we can establish pulmonary artery flow. Sometimes delayed sternal closure is done, and it also required revision surgery due to fall in pulmonary resistance following initial operation, and this need can be minimized by timing the surgery appropriately. Now patient presented with obstructed systemic blood flow, they have two procedure of choice. First is a DKS procedure. It is a short form of Damas Kyle and Stencil procedure. It is indicated in arch hypoplasia with coarctation or subaortic stenosis, or patient presented with restrictive bulboventricular foramen causing outflow tract obstruction. So if interventricular communication at the level of VSV is less than 1 to 2 centimeter square per meter square, then DKS procedure is advised. In this procedure, there is an anastomosis between the pulmonary root and ascending aorta is done, and through this procedure we achieve unobstructed systemic blood flow, and it will maintain cardiac output. Similarly, simultaneously we also prevent hypertrophy of the ventricle, which compromise future palliation. We have to do simultaneous BT shunt to control pulmonary blood flow. Another approach is the direct enlargement of interventricular communication, but you have to enlarge VSD, but it is very challenging in neonate, and there is high chances of complete heart block in this patient. Second procedure for obstructed systemic blood flow or restricted or duct dependent systemic blood flow is a Norwood procedure. It is done in hypoplastic left heart syndrome and performed in the newborn period with ECMO support. The procedure is as shown in the figure. Aorta is open longitudinally, and pulmonary artery is used to construct new aorta, and the so it will achieve unobstructed systemic blood flow, and the pulmonary blood flow given with either central shunt, BT shunt or Sano shunt. Here Sano shunt is preferable because it will not in the BT shunt and in central shunt there is a high chances of coronary steal, and it will affect the immediate postoperative period, management in the immediate postoperative period. So Sano shunt will not have any coronary steal, and there is a better growth of pulmonary artery. Now on the alternative to this Norwood procedure is the hybrid procedure. Here it does not require CPP and done inside cath lab with both the cardiologist and surgeon. Here it is indicated in premature child with low birth weight and with infection. Here they do atrial septicectomy and pulmonary duct stenting, and surgically we have to do bilateral pulmonary artery bending. So we will achieve unobstructed systemic blood flow and control pulmonary blood flow. But the disadvantage of this hybrid procedure is it is a catheter based reintervention required to enlarge arterial septectomy, and another there is a high chances of retrograde arch obstruction. Now in second stage of which is done in infant period, it is we have to do superior pulmonary connection. The goal of the second stage is surgical connection between the SVC and ipsilateral pulmonary artery. And the second goal is we have to reduce volume load and allowing time for remodeling for the ventricle before final surgery. And third goal is to perform any additional procedure like pulmonary arterioplasty, septictomy and valvuloplasty if it is not done in the previous stage. Now the surgery for increased superior pulmonary anastomosis is the classic Glenn shunt. Here end-to-end anastomosis between right pulmonary artery and SVC is done. It is done by Dr. William Glenn, but it has some disadvantage like loss of confluence in pulmonary artery and right to left shunting caused by the cyanosis and pulmonary AV fistula. So modification of this occur and it is known as bidirectional Glenn. Here end-to side anastomosis between SVC and PA done. And advantage of BDG over classic Glenn is the here preservation of confluence between right and left pulmonary artery with minimal distortion of PA. Another approach is you have to do Fontan operation. It is physiologically is similar to Glenn surgery, but certain disadvantages like it requires cardiopulmonary bypass. It is more complex and there is high chances of transient sinus node dysfunction. But on the advantage, it has very low complication and reintervention at the up to 1 year of age. And through Fontan, it is easier to do lateral tunnel Fontan. In this procedure, they anastomose SVC to the pulmonary artery in a such a way that upper body blood will directed to the pulmonary artery, and the lower end of SVC they put patch, so the SVC blood will not go to the RA, and during final stage of lateral tunnel Fontan, they have to create buffel and remove this patch to complete Fontan. Another procedure is a Kawashima procedure. It is similar to Glenn, but it is indicated in the interrupted IVC case, IVC patient. Here what happens, all the venous return from the body except hepatic venous return will come to the SVC, and IVC is a continuation of azygous vein. So by doing bidirectional Glenn in this patient, there is high chances of failure because pulmonary vasculature it is not mature enough to accommodate such an increase in blood flow, and you will receive resting saturation around 87 to 92%, and there is high chances of development of pulmonary AV malformation, and it is not recommended as a long-term solution. Now we will see what happened after bidirectional Glenn. What are the changes in the physiology of circulation? So before BDG there is a multi-distribution circulation, but after BDG we will convert into series circulation with 40 to 60% shunting at the level of IVC. So it will significantly reduce the volume work of the ventricle, but it will lead to mass to volume mismatch, and it will leads to diastolic dysfunction. So this decrease in ventricular function which typically recover in 2 to 6 months. But one another thing in this patient there is an increase in intracranial pressure due to increase in SVC pressure, and the patient will present with transient irritability and Cushing like response. So there is reflex hypertension and bradycardia in this patient. So if this high gland pressure will present for prolonged time, it will lead to reduction in the pulmonary blood flow. This is due to by diverting pulmonary blood flow away from pulmonary artery to the veno-venous collateral, which is present in the cerebrospinal venous system. It is also known as Batson plexus, and it will divert pulmonary blood flow to the if high gland pressure will persist post-operatively, then it will divert pulmonary blood flow away from pulmonary artery through the veno-venous collateral in the lower body. by this spinal venous system and Batson plexus. So it will reduce pulmonary blood flow and patient presented with hypoxemia. One another strategy to increase pulmonary blood flow is to open this shunt or partial bending of the pulmonary artery. So it will improve pulmonary blood flow and it will increase pulmonary artery growth and improve oxygen saturation in the patient, and it will provide continuous supply of hepatic factor, and it will leads to reduction of AV malformation. But it has some disadvantage like volume loading of this heart. Higher gland pressure leads to longer hospital stay and pleural effusion and chylothorax. So perioperative care in BADG patient is very important. So we have to put CVP cannula in the lower limb, and we have to keep minimum duration of mechanical ventilation, because higher intrathoracic pressure increase cerebral venous and SVC pressure, and it will lead to decreased pulmonary blood flow. And cerebral autoregulation and pulmonary blood autoregulation work in different ways. So if there is a hypercarbia, it will increase cerebral blood flow, but hypercarbia cause pulmonary vasoconstriction. But cerebral blood flow is a obligatory flow to the pulmonary circulation. So the ultimate effect is a increase in pulmonary blood flow. Similarly, hyperventilation leads to decrease in cerebral blood flow, and it will further decrease pulmonary blood flow. So we have to avoid hyperventilation, ventilation and hypoventilation post-operatively. And if patient have a high PVR and reduced saturation, then inhale NO and other pulmonary vasodilator can be used. So typically gland pressure following uncomplicated BDG is around 15 to 17 mm of Hg. Transpulmonary gradient should be around 8 mm of Hg, and arterial saturation is around 80 to 85%. So if arterial saturation is less than 75%, then it requires prompt investigation, and mortality of these surgeries are less than 2%. Now the complication commonly present is unanticipated hypoxemia. It is due to either due to reduced mixed venous oxygen saturation. The reason will be reduced cardiac output, AV valve regurgitation, or outflow tract obstruction. Second cause is due to decreased pulmonary venous oxygen saturation. It will leads to increased transpulmonary gradient, and the causes are lung disease, pneumothorax, and pleural effusion. It may be due to decreased pulmonary blood flow by these veno-venous collaterals. Second complication is hypertension. It is reflex mechanism due to increased cerebral venous pressure, and we have to avoid doing aggressive treatment in this hypertension, because it will reduce cerebral blood flow. Another complication is sinus node dysfunction. Then this patient have SVC syndrome. This is also due to higher SVC pressure, and infant become irritable for 2 to 4 days and presented with upper extremity edema and plethora. Another complication is pleural effusion and chylothorax. Here, if chest tube drainage for more than 1 week, it is called chylothorax pleural effusion and persistent pleural effusion, and it occurs in 15% of patients, and the reason is relative obstruction at the drainage of lymphatic fluid due to rise in SVC pressure. Last complication is pulmonary AV malformation. It is probably due to loss of hepatic factor, which is not supplied in after gland. Now stage 3 surgical palliation, it is Fontan procedure. Here goal of Fontan procedure is creating surgical baffle between IVC to pulmonary artery and minimization or elimination of hypoxemia. Perform an additional procedure if it not done in stage 1 and stage 2, like pulmonary arterioplasty, septectomy or valvuloplasty, and almost complete separation of systemic and pulmonary circulation and restoration of in-series circulation. So these are the list of 10 commandments that given by Chaucer and Fontan in 1971. These are 10 things you have to look for ideal Fontan candidate. So patient should have age greater than 4 years. They have sinus rhythm and normal systemic venous drainage, normal size right atrium, mean PA pressure less than 15, PVR less than 4 UD unit, pulmonary artery and aortic dimension diameter ratio 0.75, ventricular ejection fraction greater than 60%, and no AV valve dysfunction and no impairing effect from PVS shunt. But apart from these 10, these three are more important. We have to look for it. First is the mean PA pressure. It should be less than 15, and PVR should be less than 4, and simultaneously there is no UR dysfunction. Later on, Graham and John pointed out some critical criteria which is not included in this 10 commandment. It is a diastolic dysfunction. You have to look for it: ventricular hypertrophy, then systemic outflow tract obstruction, then right ventricular type of single ventricle, and extensive systemic aortopulmonary collaterals. So if patient have these five symptoms, then they are not ideal candidate to do Fontan surgery. Now, surgical strategy in Fontan is mainly two surgery: extracardiac Fontan or lateral tunnel Fontan. And one variant of extracardiac Fontan is intra-extracardiac Fontan. And lastly, surgical fenestration. So there is no clear-cut indication to do either extracardiac Fontan or the lateral tunnel Fontan. But according to hydrodynamic study, the lateral tunnel Fontan and extracardiac Fontan provide smooth caliber and unobstructed Fontan pathway, which leads to reduced energy loss and improve cardiac output. While the original Fontan used right atrium as a pulsatile chamber, as a pumping chamber, so it has increased energy loss and reduced cardiac output. So for the timing of Fontan operation, it is done between 18 months to 4 years of age, and by the age of 2 years, pulmonary vasculature will develop so that they accommodate cardiac output with only modest elevation of central venous pressure. Now there are some criteria for early Fontan. So like if patient develop intrapulmonary AV malformation or acquire aortopulmonary collaterals, or patient becomes symptomatic and cyanotic after BDG, so they require early Fontan. Now there is a contraindication to do Fontan. So if pulmonary vascular resistance greater than 4 Woods per unit, so we have to avoid doing Fontan. If pulmonary vascular resistance between 2 to 4 unit, then BDG or hemi-Fontan or fenestrated Fontan is a better choice than a complete Fontan operation. And if ventricular end diastolic pressure is more than 10 to 12 mmHg and ejection fraction less than 45, then again it is raised question for suitability of Fontan repair. So you have to look for pulmonary vascular resistance, ventricular end diastolic pressure in a pre-Fontan angiography. Now this is the original Fontan procedure which done by Fontan in 1971, and it is done for tricuspid atresia. In this procedure they have done classic Glenn shunt and then closed foramen, and anastomos is done between right atrial appendage and proximal end of divided RPA. They put two allograft, first is junction of RPA and right atrial appendage, and second at IVC ostium. So here RA is used as a pump to assisted by IVC valve and valve at axis of RA to the left lung. Disadvantage of this procedure is that the reoperation for conduit obstruction is required, and durability of valve process is limited, so we have to do reoperation, and here coronary sinus is exposed to very high pressure. Now in extracardiac conduit Fontan operation, it is done by Marcelletti in 1988. It is done through the midline sternotomy. Here IVC is anastomos to the pulmonary artery through PTFE graft around 2 cm of the size, and the fenestration is put between RA and this conduit. So it is extracardiac conduit Fontan operation. It has some advantages like right atrium is not exposed to the high pressure. It is less arrhythmogenic as no RA suture line, and it can be performed with or without aortic clamping and even without cardiopulmonary bypass. While the disadvantage is you have to use prosthetic material, there is high chances of graft thrombosis, conduit obstruction, there is no growth potential as it is a prosthetic material, and it is difficult to reoperate and take down this surgery, this shunt. Second technique is a lateral tunnel Fontan. It is done by D level in 1988. Here IVC is anastomos to the PA through inside creation of baffle in the RA, and there is simultaneous fenestration is also done. So it is a continuation of hemi-Fontan procedure, and advantage is it has a growth potential because part of right atrium is used, so it will grow, and you can easily do fenestration in this surgery. And here there is a streamlined laminar flow similar to extracardiac Fontan, and there is no separation of atria or avial closure is required, and coronary sinus will not expose to the high pressure. Disadvantages are CPB, hypothermia is required, and myocardial ischemia can occur, and manipulation of tissue around the region of SA node and SA nodal artery will cause sinus node dysfunction, and there is a risk of stroke also. Now fenestration has some benefits and risks. So this fenestration allows blood flow from conduit to the right atrium. So it sends blood from right to left to lower central venous pressure and augment ventricular output. It improves systemic output and tide over the transient period of increased pulmonary vascular resistance post-operatively. So it is beneficial. It lowers CVP and reduces persistent pleural effusion post-operatively, and it will shorten the hospital stay as well as chest tube output. And it is used as a strategy to manage late complication of Fontan like protein losing enteropathy, plastic bronchitis. But fenestration has some risk also there, because there is a right to left shunting, there is a desaturation and incomplete relief of hypoxemia, and there is a chances of paradoxic embolism and stroke. Now intra-extracardiac Fontan operation is a variant of extracardiac Fontan. It is suitable for complex type of presentation like apico-caval juxtaposition, in which the LV apex will sit over the IVC, so you cannot do extracardiac Fontan. So here through an arteriotomy, a conduit is anastomosed to the entrance of the inferior vena cava, and the conduit runs through the atrium before existing to the roof and continue as a pulmonary artery. Here fenestration is created with the intra-atrial portion of the conduit. So it is another technique in complex positions. Now perioperative care in the Fontan patient is very important. In the monitoring part, we have to measure SVC pressure, which is a gland pressure. IVC pressure is as a Fontan pressure, pre-Fontan pressure, then pulmonary artery pressure, and simultaneously atrial pressure, and also measure the transpulmonary gradient. So difference between SVC and IVC pressure should be less than 1. CVP or pre-Fontan pressure should be 15 to 18, and transpulmonary gradient should be less than 10. And the saturation should be more than 90%, and if fenestration is done, so that it is more than 80%. So for general measure in the perioperative care, we have to use semi-fowler position to increase venous return. We have to put bilateral chest tube and pacing wire, which is mandatory. And this patient has a preload deficient, so they require high volume post-operatively, and they require blood products, and this is a redo surgery, or it also requires CPB. And the Milinon is the choice of inodilator as it reduces pulmonary vascular resistance and increased cardiac output. Negative pressure ventilation is preferable in these patients, as spontaneous breathing improve pulmonary blood flow and cardiac output. Now Fontan failure is a very important to manage. To identify what are the causes of Fontan failure, you have to measure central venous pressure at the IVC level, pulmonary artery pressure, and atrial pressure. So if CVP or IVC pressure, then and pulmonary artery pressure and atrial pressure all are high, then there is a cause of ventricular dysfunction, and you have to give inotropes. Other cause may be AV valve regurgitation, so you have to do redo surgery, or you have to repair the valve. And other cause are cardiac tamponade or positive pressure ventilation. So if there is an increase in CVP and PA pressure, but with normal atrial pressure, it indicates there is a high transpulmonary gradient. So the causes are pulmonary vascular occlusive disease or hypoplastic pulmonary artery, or there may be higher PVR. And treatment option is you have to give inhaled nitric oxide, Milrinone, or you have to do hyperventilation. Similarly, if only CVP is high and pulmonary artery pressure and atrial pressure is normal, then it indicates there is a conduit obstruction, and you have to redo or take down the conduit. And the last possibility is the patient has a normal or low CVP, normal PA pressure, and normal atrial pressure. Then it will indicate hypovolemia. You have to give volume to correct this. Now, complication following Fontan is the deleterious like atrial arrhythmia. It present in 30% of patients and it leads to morbidity and functional decline. And most common type of arrhythmia is sinus node dysfunction, jet, and atrial arrhythmia other. The treatment is temporary pacing, amiodarone, body cooling, and pain control. Another common complication is cardiothorax. It present in up to 25% of patients. Here, chest tube drainage more than 1 week is required to diagnose as a cardiothorax. So, the reason is the leaking microvascular pores enlarge over the time with passage of chylomicrons. And the treatment is a fluid restriction, diuretics, TPN, and thoracic duct ligation. Another complication is the protein losing enteropathy. It present in up to 13% of Fontan patient by the age of 10 years, and it is the reason is the increased venous pressure in splenic territory, which leads to loss of lymph and protein in intestine and post-operative low cardiac output. This patient have a generalized edema, pleural effusion, and ascites due to decreased serum albumin, and 50% mortality in 5 years after diagnosis. So it is very dangerous, and the treatment is a fenestration. Either you give sildenafil or reoperation and the transplant. Another complication is the plastic bronchitis. It is due to airway obstruction due to fibrous and mucosal material, and the treatment is bronchoscopic lavage and respiratory physiotherapy. Another complication is thromboembolic complication and neurological complication. Now, result of completed Fontan operation are 30-day hospital mortality currently is 0 to 4%, and survival at 10 years is around 50 to 90%, and at the 15 years it is 50 to 80%. And we have equal result with extracardiac conduit or lateral tunnel technique. Functional status achieved after Fontan operation is that 94% of patients have will be in the class 1 or class 2 of NYHA, and 90% patient will present with class 1 at the age of 1 year, and this NYHA functional class gradually deteriorates over the time, and this operation after this operation somatic growth does not improve, and in series of 216 tricuspid atresia patients undergoing in the Fontan over the 25 period of time in Mayo Clinic has a result like overall survival was 79%, and 1 to 5 year survival around 90%, and in another study of Petrosian and colleague 10-year freedom from Fontan failure of any kind like death, takedown, and transplantation is 90%. Now these are the most common mode of death after Fontan operation, and as you can see there is a 73% cause of death is a cardiac failure. Other common causes are persistent fluid accumulation and neurological dysfunction. Now, transplant following Fontan operation, the indication is if patient develops severe ventricular dysfunction with high end diastolic pressure, and if PVR is elevated at level that Fontan circulation will fail. Another complication of Fontan like protein losing enteropathy and plastic bronchitis, then transplantation is indicated. Survival of after transplant is similar to other patients undergoing transplantation, like 1 year survival is 72% and 5 year survival is 68%. Now to conclude my session, the take home messages are functional univentricular heart support both pulmonary and systemic circulation. It is a multi-distribution circulation with volume overload. Goal of the management is the complete separation of systemic and pulmonary circulation and restoration of in-series circulation. Fontan pathway eliminate volume load and cyanosis and provide highest possible cardiac output at lowest possible CEP. Survival into 4th and 5th decade of life with successful pregnancy and exceptional quality of life is possible. Thank you.